So I would like to give a little background on Dr. Deepa Rajan. She's an associate professor of pediatrics in the Division of Neurology at the University of Pittsburgh School of Medicine. She received her medical education from Bangalore Medical College and Research Institute in India, and completed training in pediatrics at the Children's Hospital of Michigan. She then completed training in child neurology at Children's Hospital of Pittsburgh and stayed on as faculty with the Division of Child Neurology. I'll read a little more. She initially established and directed the neurogenetics clinic and program at Children's Hospital of Pittsburgh to harness novel genetic technology for the diagnosis and care of patients with undiagnosed diseases. Subsequently, she was appointed clinical director of the program for the study of neurodevelopment in rare disorders. In 2023, these programs were consolidated, and Dr. Rajan is currently the director of UPMC Children's Center for Neurogenomics. Thank you so much for joining us today.
Thank you very much, Cindy. I will be honest, I had an existential crisis a few minutes ago trying to think about what I am really going to talk to you after you've had an entire day's discussion of Gaucher's disease. And I'm talking to people who are living it and know more of it than I ever will. And so I asked myself, what am I going to speak to you? And I have fervently changed some of my slides to accommodate the situation. I am literally standing on the shoulders of giants. We had 3 experts speak before me. I'm just starting off in Gaucher disease, so I am literally standing on the shoulders of all of these experts, and I am truly humbled by all the history that I heard from all of you here today. So thank you for giving me this opportunity, and thank you for really tolerating some of the things that I'm going to talk to you about now. I do have disclosures. I have grant funding, and I'm site PI for multiple neurodegenerative diseases at Children's Hospital of Pittsburgh, but none of it is really related to this talk. What do we do? So I head a center at Pittsburgh. It's called the UPMC Children's Center for Neurogenomics. The vision of the center is to move rare diseases from the space of discovery to treatment. And you all have been living this history. So our group works on multiple different neurogenetic disorders, hoping to get them into diagnosis and then moving patients from diagnosis to establishing a natural history, trying to find biomarkers, then clinical trials, and hopefully, finally, treatment. I'm not going to cover most of that slide, but that essentially tells you what we try to give our patients in our clinic, right? So in my mind, any question that is worthwhile answering comes out of clinic. And the time that we spend with all of you in clinic is how we get to some of our most important questions and hopefully some trials and treatments down the lane. So our clinic has done a lot in new gene discovery, and it has had impact on research and education. We are part of many clinical trials, including 3 gene therapy trials and one that was for GD2 that Sarah talked about. We also have a lot of investigator-initiated natural history trials that hopefully will help one day to get treatment to many children with neurogenetic disorders. These are pictures of some of our students who have presented in various conferences. I had these slides, and I decided I'm not going to talk about it. You guys know more about it. I'm not going to talk about what Gaucher disease is. You guys know where it comes from, the biochemistry. But I really wanted to give you a perspective of what really we as physicians, as clinicians sitting in clinic, see. And when we see a patient with a disease, what are we really thinking about? And this comes to mind, and many of you have heard about it. It's the 10 blind men that look at an elephant in the room and give different descriptions. So I truly think that when we are dealing with a rare disease, this comes in this is in action. Whether it's a neurologist, it's a geneticist, it's a hepatologist, it's a scientist, we are all looking at different perspectives of the same disease. Unfortunately, none of us really are equipped. None of the 10 blind men individually are equipped to look at that elephant in the room. We can only do it together. And I think that's important that we come together as this alliance is doing. And I put that fractal down there because as a disease moves from diagnosis to natural history to treatment, it starts simple, so we can define diseases and say, okay, there's a type 1, there's a type 2, there's a type 3. That comes along in the beginning stages of the disease. But as we discover more and more, the complexity of it becomes significant. And then we'll have to go back and relook at it and ask ourselves, are we really doing ourselves a favor by maintaining the same classification that we did early on? What does a neurologist do? So like the 10 blind men looking at the elephant, my job is to give you a perspective of what a neurologist would do for Gaucher disease. And the topic that I was given was neuronopathic Gaucher disease. And I struggle with that. Like, what is neuronopathic Gaucher disease, right? Before we said it was type 2 and type 3 alone, but now we know, okay, there are some people with type 1 who can have neurological symptoms. And so in my mind, that's why I changed the topic to say neurological manifestations in Gaucher disease. I don't think we can restrict it to the type. So when you see a neurologist, and I presume not many of them have heard of Gaucher's disease or have dealt with Gaucher's disease. But what are they doing? They're looking at it from their training's perspective. So they look at you and try to assess different parts of the nervous system that they can define. So a neurologist is trained to look at the central and the peripheral nervous system and define it in clinical terms. So they describe your mental status, they look at your cranial nerves, they do a motor exam, they do a sensory exam, and then look at your coordination and gait. And how could they do it if they were to fine-comb some of this? And I heard many of you have been part of natural history studies. So when you fine-comb your cognitive function, people can put you through different scales depending on your age group. So if your child is much younger, people are looking at your development to see how the higher mental function and your cognitive evaluation are. If you are much older, then you're looking at IQ tests and intelligence scales to look at what your cognition scales are. How is this important? For each one of us sitting here, this trajectory is going to be different, right? And so if you follow your norm, then you will know what your norm data is, and that's how we can figure out if a drug is effective for you or not. Neurological manifestations of cranial nerve. I'm going to see if any of my videos work, because I know Dr. Gaucher didn't, but well, maybe it is working, isn't it? Well, maybe not. Maybe, if you can see some of it. Essentially, even at the stage of a newborn, you can have extraocular movement. So if you see that child can follow that object with eye movements from right to left without the movement of the head considered. But many of our children with GD2, unfortunately, have very restricted extraocular eye movements. And to me, these are two extremes, right? This is normal to significantly abnormal, but many of us lie in that spectrum of abnormality. So we could have very minimal extraocular movement abnormalities that may or may not be detected unless your physician knows that they have to look for it. You could have hearing abnormalities. And in the severe end of the spectrum, many of our GD2 patients have severe dysphagia, inability to swallow, inability to coordinate their cough, and hence significant drooling. Are there things that you can do for it? Yes, there are things that we can do for it. While we are talking about different treatments that are emerging, what is important right now is what can we do about it symptomatically. what we realized and, along the course of the trial is if we can control these secretions, if we can get Botox onto the salivary glands, if we can control the vocal cord dysfunction, we might be able to provide these children a better quality of life and possibly a safer exposure to anesthesia and MRI if these are addressed ahead of time. This has already been talked about, so there can be significant abnormalities in your motor function. I walked into the room to see all of you, and it gave me a complete different perspective. Recognize I'm a child neurologist, and most of the patients that I saw were GD2 patients, so I saw the other end of the spectrum. And when I walked in here and saw, I realized that we have a whole spectrum of neurological symptoms, which could be very, very mild. But in children who are very severe, we can see what we call central hypotonia, where they're not able to control their neck and their core muscles, or we can also see peripheral hypertonia, meaning that they are significantly spastic. Many of these children can have what we call ophistotonus. When you lay them down flat on their bed, they're unable to, they're holding their neck flexed back. And so it can range from having low tone to high tone, and then as they move along in the juveniles, we can see extrapyramidal symptoms, so Parkinson's-like tremors, though they're not Parkinson's. These can all be symptomatically managed. There was a question about, what sort of dementia do I have, right? And it leads me back to that figure of that elephant to say, these are all terms that clinical medicine uses to describe what they know at that point of time, right? Hopefully, 10 years down the lane, we might look back and say, oh, Lewy body dementia, these are all the genetic changes. But right now, we don't have that. We have only the terminology that we can use to describe some of these symptoms. Many of our patients have peripheral neuropathy, so it's very hard in children to express some of these symptoms. They can be very uncomfortable, they can be irritable, but that could be from their symptoms of peripheral neuropathy, which would be much easier to describe in adulthood. And we tend to see neuroirritability in our younger children. They do resolve with drugs like gabapentin, positioning, and skin and joint care. Seizures and ataxia, these are coordination problems and then higher motor function problems with seizures. Recognize that a definition of a seizure is what we think of as an abnormal discharge from the gray matter, right? And so that could be clinical versus non-clinical, meaning you could show symptoms of it, or we could only find it when we see it on an EEG. Both of them warrant treatment if there are abnormal discharges in the brain that do have evolution to qualify as a seizure. But there's the flip side of it that's also possible. You can have abnormal movements without having abnormal EEG, and that could be more of a movement disorder rather than an epileptic disorder. And why is that fine-tuning important? The medications that we have for both of these would be different. So if I have a child who has myoclonic epilepsy, I would use a different group of medications. But if I have someone who has myoclonus but doesn't necessarily have abnormalities on the EEG, my medication armamentarium will be different. Many of our children do have seizure-like movements that don't land up to be epilepsy. It could be as simple as reflux, it could be clonus, it could be movement disorder, and many neurogenetic disorders in children can have staring spells which don't land up to be absence seizures. As our children get more severe and more neurodegenerative, we do also see abnormalities in the autonomic nervous system. So problems with temperature regulation, abnormal changes in the heart rate and the respiratory rate, abnormal changes in tone without any specific underlying reason. And these can be addressed with medications as well. So overall, if you have Gaucher's disease but don't have access to a center that is aware of it, do know that your neurologist is probably going to be able to evaluate each of these even without their baseline knowledge. But this is something that you can have them follow with time. How, it really helps for someone to know the disease because they know what they're looking for. It's easier to anticipate. If I know that a child is going to have Gaucher's or Krabbe's or Hunter's, I know what symptoms I'm looking for. So I might be able to figure it out much earlier. And it's always the case that my patients and the parents of my patients know their symptoms much ahead of when I am able to objectively diagnose them. Neuroimaging, unfortunately, has not been very helpful with Gaucher disease. We have non-specific white matter changes, but even in children who have significant neurological symptoms, many times we find normal MRIs. In the research level, there might be DTI and MRS abnormalities, but these are things that are not really seen at the clinical stage. EEG, you can have abnormal EEGs without having seizures, and you can have seizures without having abnormal EEGs. So that's where I think the art of clinical medicine becomes important. And I think, as many people have spoken before, you want someone who can look at you as a whole, as a patient, rather than just the lab work or your EEG results. You want them to put it all together. There can be abnormalities in the ABR and VEP, which is essentially tests that look at your sensory organs, so your hearing and your vision, and see how those inputs are transmitted to your brain. And that we usually see abnormalities with in Gaucher disease. I want to summarize by saying we started off understanding Gaucher disease, and it's curious that I use the same tip of the iceberg that Dr. Gaucher had used before. But when we started describing the disease, it's easier to pick the severe end of the spectrum. So we said, okay, there's type 2 disease. And the initial studies said type 2 is very homogeneous. It has severe neurodegeneration in the first year of life. Many children will pass away with neurodegeneration in the first year of life. But this was the tip of the iceberg. What we have realized with time is that while we can, survival is significantly improved with our treatments, we haven't unfortunately been able to address the neurological symptoms of our patients. We thought type 3 is the intermediate between the type 1 and type 2. But even in that, what previous studies have shown is that the IQ can be fluctuant. So there can be interpatient changes, and even within the same patient, there can be fluctuations in IQ with time. So how do we really assess some of these symptoms? In type 1 patients, where we thought we would not have any neurological symptoms at all, with time we now know we can have a variety of neurological symptoms. You can have a risk for Parkinson's disease, you can have peripheral neuropathies, there's psychiatric symptoms, seizures, oculomotor dysfunction, and occasionally tremor and myoclonus. So I go back to this to say, we are all endeavoring in trying to understand the disease, but we really are like blind men describing the elephant, and we got to work together to put it all together. Essentially, this slide was to show, we said, okay, type 2, type 1, and type 3 are three distinct types, but what you heard many experts say today is that this is a spectrum of disease. So even if you got that label of type 1, type 2, type 3, recognize you're somewhere on that spectrum. And where you are, that's where you need your physician to personalize your treatment for you. Treatment strategies has already been talked about. There are many different treatment options, and there are many emerging treatment options. But do know this, that every treatment option is going to come with a scale of risk versus benefits. And depending on where in that spectrum of disease you are, you're going to weigh that risk versus benefits differently. If I'm going to, if the treatment option is an intracisterna magna injection of a gene therapy, I would weigh the risk versus benefits of that differently when I have a child who's severely affected by it compared to an older adult who has not had significant neurological symptoms. So you will have to know, you yourself and your care team will have to know where in the spectrum you lie and help you understand what the risk versus benefits of any of these treatment options that are coming down the lane. And more importantly, the neurological symptoms don't stand alone, right? So if you have long-term neurological symptoms, you have secondary effects. So children who have significant increase in tone can have secondary skin changes, secondary bone changes, and secondary issues with their hygiene, with their dentition, and all of these would need to be addressed too. Right? If you are significantly hypertonic, your chances of reflux is increased. If you have severe neuronopathic Gaucher disease, it could affect the nervous system controlling the movement of your gut, and you could have constipation. You could have problems with bladder control issues. So these are secondary issues, though I still see it as neurological because they're secondary to long-term neurological involvement. So overall, I want to conclude by saying, we all lie in a spectrum of normalcy, and what would be personalized optimal care is to look at all of this, have all of those 10 blind men together work with you to find out where in the disease you are and to help you optimize each one of those and help you assess the risk versus benefit of any of the new treatments that are coming. So overall, this is going to be teamwork between you and us, and I'm hoping that we will continue the good work together. Thank you for giving me this opportunity.